Good evening, everyone, and welcome to the second part of the Columbia Bioethics Master's Program and Columbia University Law School webinar on addressing implicit bias as standard of care, organizational ethics, and solutions. And I'd like to welcome my co-panelists, Jorge, Didi, and Julia. It's a pleasure to have you all with us. I should say that if you didn't get to see part one of this program, it is available online at the Columbia Bioethics webpage. Just Google Columbia Bioethics events. And that was the clinician's perspective. We had a wonderful presentation by Nikia Alexander, a nurse at the medical center. And today we're taking the bigger step forward, which is to address the systemic and organizational responsibilities that we have as a legal and ethical obligation to promote not just good health care and redressing implicit bias and microaggression and systemic racism in the actual provision of care, but also at the organizational level and in promoting health more broadly, because it is well past time that we get beyond the notion that we are only in the healthcare business. If we are doing what we ought to be doing normatively, we should be promoting patients' health with the hope, obviously, that we're going to be able to keep patients out of the hospital. And to remind ourselves that this is always about people and that the decisions and actions that we take on an individual patient basis and in managing and directing, mentoring the healthcare delivery system. I would like to dedicate tonight's program to my dear friend, Jerry Giardina, who ended his battle with cancer earlier today after just a heroic struggle, which reminds me all the time how important is the work that we all do. So with that, let's take care of some housekeeping. First, if you are here to receive continuing legal education credit for the program tonight, this is your official legal instruction about CLE credit. I would ask all of you who will be seeking CLE credit, and the rest of you, if you'd like, to put your name and your email address in the chat so that we can have a record of who we have to make sure we get course evaluations and attendance affirmations from, so that we can make sure that you get your CLE credit. And let me introduce my colleagues. So I should introduce myself, David Hoffman. I'm a member of the faculty of the Columbia Bioethics Master's and Certificate Program, and am fully responsible for the fact that this topic is what we're talking about tonight. I've invited three of my colleagues and friends, some old friends, some new old friends. First, Jorge Rivera, who is variously the health counsel to the New York State Senate Majority Leader and a clinical ethicist who worked at a very large healthcare system in the New York metropolitan area as a clinical ethicist. So more from Jorge about that experience. And Julia Rezari, Julia, I hope I got that right, who is the executive director of the Dalio Center for Health Justice at the Columbia University Irving Medical Center, which is doing some really extraordinary work to broaden the conversation that we're going to have tonight. And last but not least, Daenerys Didi, as we know her, Sanchez, who is the Senior Research Associate and Project Coordinator for, this is a mouthful, but it's worth saying, the Washington Heights, Hamilton Heights, and Inwood Columbia Aging Project. And you'll learn more about that when we get to the solutions part of our program tonight. I am morally and legally obligated to point out that none of us have any conflicts of interest to disclose in connection with tonight's presentation, though we all do have interests, to be sure. And of course, opinions expressed tonight by the participants do not necessarily represent the positions of their respective institutions. So let's be clear about that. And this is what we're going to cover. We're going to talk about what implicit bias looks like at the organizational level. We're going to talk about how implicit bias impacts organizational behavior and how it influences hospitals' approach to evaluating both the quality of care and the quality of health in the community. We're going to talk about how we have tools, in this case, IT tools, to research and measure the instances of systemic racism so that we can do something about it. And we're going to close out looking at what we can and should do using those tools to both identify and quantify these problems so that we can redress instances of implicit bias that IT identifies. So there you go. That's the program. And so let's first remind ourselves, with brief reference to part one of this program, why we're here. Because this is not a usual topic for a continuing legal education program, or even, frankly, in my experience, a usual topic for professional education in healthcare and bioethics generally. And so this was a quote that Nikia Alexander shared with us in the first program, which I think is really quite remarkable. This was a quote from a patient that was interviewed for the documentary that Nikia is preparing, and it really sets the tone for our discussion tonight. As a patient that has experienced microaggressions in healthcare, it feels like you have to constantly advocate for yourself, and that is exhausting. And let's be candid, we ought not to be exhausting our patients. We should be taking care of and caring for our patients. So that's a good reminder of why we're doing this work. And speaking of this work, I decided just a week or so ago that I really wanted to start tonight's program with a case study. My friend and mentor, Nancy Dubler, is fond of saying that clinical bioethics is a matter of telling patients stories. And this is a quite remarkable one that came my way just a couple of weeks ago, January 13th at 5:35 in the morning. And I say that this is a case study on implicit bias, possibly, more on the possibly after I've read this really quite extraordinary email from a person I'm calling Maria, not her real name, but you should know for context that Maria is a person of Latin American heritage, and that seems to have influenced the way that she was treated at a hospital in New York City. So Maria sent me this email at 5:30 in the morning while she was an inpatient at a hospital in New York City and in early stages of labor. And I didn't know her at all. She found me by doing a Google search on the internet for a lawyer who did bioethics. And she wrote, "Hi, Mr. Hoffman. I am writing with an urgent need for legal advice. I am in a New York City hospital in the early stages of labor and being induced. I have had a fraught relationship with the hospital since I was admitted on Monday, January 10th, as I have rejected several of their recommendations for my care during labor and delivery in an effort to have the birth experience best suited for me, as opposed to the one best designed to protect the hospital from potential liability / the hospital's business considerations. I have advocated for myself strongly, to say the least." We would like for that sort of a sentiment, right, not to have to even be expressed, but it gets so much more interesting. I just reviewed my medical notes, which are on the hospital's online portal. I added the emphasis here. In her notes from yesterday, 1/12, the head of OBGYN at this branch of the hospital, whom I've had 3 separate interactions with during my admission, made repeated reference to, quote, my possibly needing psychiatric evaluation and being incapable of making proper medical decisions for myself and my baby. According to the notes, there were a series of meetings yesterday afternoon involving the above head of OBGYN, as well as the head of OBGYN for the entire hospital network, a member of the ethics department for the hospital, and other high-level parties discussing their plan of care for me. The note references a separate detailed note made by the ethics department employee, but that note is not included in my online chart. In addition, beginning on Tuesday and through yesterday, my medical notes have become increasingly inaccurate as far as how the staff recorded my responses to their recommendations and the conversations about my care that we have had. I am in the middle of being given medication to induce labor. At 10 a.m., I will have to decide whether to be hooked up to an IV and medicated with Pitocin, which, if successful, will send me into active labor. I am extremely concerned that the hospital is setting the stage to have me psychiatrically evaluated and deemed incapable of making my own medical decisions. I am most concerned that as labor progresses and I become less and less able to be clear-headed and calm, the hospital will attempt to justify taking away my right to make my own medical decisions just when I want to be able to make those decisions and when I am at my most vulnerable. I feel extremely uncomfortable receiving any more care here, but I'm not sure what options I have realistically to change hospitals at this point. For one, the health risks to myself and my baby, and second, I fear that even if I can coordinate another hospital to immediately receive and care for me, if I try to leave this hospital against medical advice, I will provide fodder to establish that I am incapable of making responsible medical decisions. I am a lawyer myself, so I don't expect you to respond immediately. But if you can, please do, as I need immediate help and advice. Thank you. So the reason I said possibly that this might be an incident of implicit bias and systemic racism is because, of course, I can't know, Maria can't know, none of us can know what was in the minds of the clinicians in the moment as these notes were written in the chart and as these conversations occurred with Maria. But let's face it, we need to be able to know. And though we don't necessarily need to know in this individual case, we certainly need to know if this is a systemic problem within this hospital and hospitals as a whole. And in order to undertake that effort, and in order to acknowledge that race can and all too often is an influence in the kind of care that people get, we need to take all of the systems, all of the capabilities for gathering, analyzing, and disseminating data about healthcare generally, and the instances, as we learned in part 1 of this program, where there is an obvious racial influence and an obvious influence related to medically underserved communities and communities of color and other disadvantaged and disempowered communities that need our support, that deserve to have the same respect and the same positive healthcare experience that many people do, but that not everyone does. So when I say possibly, I am highlighting, I want all of us to recognize, whether we are lawyers or clinicians or administrators or ethicists, that we ought not to jump to the firm conclusion that any one individual's motives are racially driven or driven by a bias against disenfranchised or underrepresented communities. But at the same time, we should recognize that it is more than a mere remote possibility, and we ought to commit ourselves as a healthcare delivery system to finding out and to using the ability to search medical records and do meaningful, credible academic research to determine just what is the extent of the misinformation and mistreatment that goes on within our healthcare delivery system today that we can do something about. The second half of the program, I promise you, will be more optimistic. You'll be hearing from Julia and Didi about the work that they are doing at our hospital, Columbia University Irving Medical Center, that, frankly, any hospital can do to some extent or another. True, not every hospital has the resources that Columbia University has, but every hospital, no matter how large or how small, can do more than is being done today. And this legal perspective leads us to BOATS. And BOATS is not an acronym. BOATS refers to boats, vessels in the water that people use to move themselves around. And how, you ask? Well, it may not seem obvious at first, but it will by the time we finish this discussion. What we're talking about is this court case, Boatland of Houston, Inc. versus Bailey, commonly referred to as In re Boatland. It's a 1980 case before, of all things, the Supreme Court of the state of Texas. And Boatland was about the failure of the manufacturer and distributor of a particular kind of fishing boat to incorporate in its manufacture and distribution a very simple safety device that, if it had been incorporated, would have made this boat safer and would have avoided what was a fatal accident. So in Boatland of Houston versus Bailey, the court observed as follows: the jury may consider many factors before deciding whether a product's usefulness or desirability are outweighed by its risks. Their findings on defectiveness may be influenced by evidence of a safer design that would have prevented the injury. Because defectiveness of the product in question is determined in relation to safer alternatives, the fact that its risk could be diminished easily or cheaply may greatly influence the outcome of the case. Now, in this case, which involved something called a dead man switch, a device that when somebody falls out of a boat stops the engine from operating so that the boat doesn't circle around and cut the person in half, which is sadly what happened in this case. In this case, the court concluded that the safety device was not sufficiently well known and recognized and understood to be able to easily or cheaply influence the kind of accident that took the life of Mr. Bailey. So what does that have to do with healthcare, you ask? Fair enough. Let us reflect on the observation of Justice Cardozo in Schlowendorf versus Society of New York Hospital. Cardozo said in 1914, every human being of adult years and sound mind has a right to determine what shall be done with his own body. Odd, because Schlowendorf was Mary Schlowendorf, who was in for evaluation of uterine fibroids, but that's a discussion for another day. This pronouncement in 1914 created the notion of a right to consent to medical treatment. Boatland establishes the principle that if there is something that can be done to make a system safer, whether the system is a boat or the system is a healthcare delivery system, then if it can be done easily and cheaply in relation to the enterprise, that it has to be. To fail to do so is a form of negligence and is clearly, in a healthcare context, a violation of the standard of care, the ethical and legal obligation that we have to all of our patients. And in this case, what are we talking about? We're talking about how we make sure that people are getting the same care that everyone else is getting, i.e., not influenced by implicit bias, microaggression, and systemic racism. And that needs to be part of the standard of care, because if it's not, we have no way of motivating or incentivizing healthcare systems to take these extra steps. In part one of the program, which you can watch on our website, we discussed how this same issue was confronted around availability of interpretation services for patients with limited English proficiency. And I urge you to check that out if you weren't able to attend last time. So how do we measure the way patients feel about the care that they provide? Well, we use HCAHPS. And what are HCAHPS? HCAHPS are the Hospital Consumer Assessment of Healthcare Providers and Systems. Put another way, they are those surveys that you get in the mail, often from a company called Press Ganey, that are an assessment of how you felt subjectively about your care. And they focus mainly on sort of generalized measures of quality. Did your questions get answered? Was the food acceptable? But they can be so much more. And it is tools like HCAHPS and some others that we're going to talk about in a few moments that we can use to gather data and get a better understanding of the extent to which race influences the way care is provided, such as in the case of Maria. So I'm going to ask my colleague Jorge Rivera to talk about how assessment of patient experience occurs in hospitals and how, in his experience as a clinical ethicist, he got feedback from patients and their families and what we can do with that information if we harvest it more responsibly. Jorge, the floor is yours.
Thank you, David. And I think you put very nicely what HCAHPS essentially do, this kind of survey which patients receive when essentially they leave the hospital afterwards, but they're really not helpful in terms of addressing or capturing that implicit bias, right? And other things we currently do besides HCAHPS, we, under New York law, for example, we have the quality assurance programs. And these are really planned and systematic processes for monitoring quality and appropriateness of patient care in a hospital system. And some hospitals deal with this as an actual division in their hospital, and they have people dedicated to monitoring certain data, certain, so to speak, KPIs, but also some hospitals have really gone beyond and created, for example, boards or committees that offer some sort of educational intervention in their programs. And for the real example, for example, is a clinical ethics committee, for example. You can see that as a quality assurance program. It's not the only one, for example, but it's some sort of quality assurance program. You also see it, for example, in tumor boards and how they talk about certain cases, and that becomes an educational program for the clinical staff, right? And besides these quality assurance programs, you also have risk management, which kind of provides some sort of quality intervention for the hospital system, but this is a little bit different because they're managing, as the word suggests, a risk, right? It's not really trying to expand the quality of care, so to speak. They're responding to some sort of risk that it's kind of reactionary in a sense. But beyond that, we also have Joint Commission standards for hospitals that follow the Joint Commission standards, for example. And here, we're not really reinventing the wheel. These are essentially the same thing, creating monitoring systems, collecting data, giving units targeted feedback, for example, implementing work policies that promote certain procedures. And again, beyond that also, then you have policy and procedure divisions that deal with certain particular standards of care or particular processes that should be in place. And they promote that agreement and teamwork within the hospital to address certain types of hospital care and standards of care. And essentially, this is like a very quick rundown of what we have right now in the arena to address certain standards of care or certain quality or in patient care.
And Jorge, tell us, how did this interact with your work as a clinical ethicist? And giving the case of Maria that I read as a case study or as an example, how could these tools be used to ferret out implicit bias and systemic racism in a hospital setting so that we know that we have to focus our attention on this or that area?
Right. And as a clinical ethicist, when I was at a big hospital system, of course, not all hospitals have that sort of capacity, but for example, in our clinical ethics division, we would have some sort of like a cloud service, so to speak, where we would have all of our consults input into that, and we were able to sift through data, we were able to identify certain measures, and we can see trends, things that are not going right, and over time you can identify these several issues. And in terms of how to address implicit bias with data, besides collecting, of course, you have to do something with it, right? And part of the exercises that we were able to do, for example, is educating staff. And it can be in the form of creating policies and procedures. For example, I was involved in creating policies and procedures. For example, education of the staff. And like I was saying earlier, between ethics committee meetings or targeted interventions to certain clinical teams, depending on the types of trends that we would see in the data, right? And those are very practical ways of dealing with this first.
That's terrific. And Jorge, what was your reaction to my reading that email from Maria as a clinical ethicist? The discussion about the fact that there was an ethics consult and that note was missing from the chart and she was kept in the dark. What was your visceral reaction?
Well, first I wanted to read that. I wanted to just see what it had, right? But it's very interesting that they never, in a sense, or at least what the patient says, they never went to her and spoke to her as an ethics division or as an ethics consult, right? Or at least the first like rule of thumb is the patient, right? And that was something that quickly jumped out of your narrative. Like, why is this patient not even aware that there was an ethics consult since we're supposed to talk to the patient, right?
That is, I think, the problem. And I want the rest of our discussion tonight to be grounded in the notion that patients, for good reason, that we're going to talk about when we get to meaningful use in a moment, patients are able to find all sorts of information about their care in real time, which is remarkable in a good way, and in this situation, really quite problematic because that access highlights what is missing. And the fact that there was reference to this ethics consult, I don't know about you, Jorge, I find that really very troubling. I think that is itself a sentinel event, a signal that we need to take better responsibility for all of this access to care that we're providing to patients. Do you have any sense that ethics consult notes ought to be posted as part of the patient's chart? How do you feel about that?
Yeah. I mean, they in a sense we indirectly become part of the clinical team in certain ways. So when we recommend a certain treatment or a certain not treatment, so to speak, but when we recommend a certain way to go about things or way to discuss certain situations, definitely it should become part of the medical record because it is going to, in many ways, determine how you're going to deliver the type of care. You know, people, I don't want to say it that way, but essentially when I would go in and it was like, oh, here comes ethics, right? And when whatever ethics says is going to be the correct thing. So people will listen to the ethics division or an ethics consult. So it will determine the type of care the patient is going to get in certain ways. So it definitely should be part of the medical record, no doubt.
Okay. Thank you so much, Jorge. Let's move on. So, if there were any doubt in anyone's mind that this is a very real, tangible problem, albeit we don't yet have a complete set of tools to quantify it, one needs only to look at the case of Jahi McMath, which was just tragic in so many ways, in a clinical sense, in an ethical sense, and of course in a legal sense. I included in the materials for the program tonight the legal briefs related to the lawsuit brought by Jahi McMath's family to get the family permission to move her out of the hospital in California, where they were quite insistent that she was brain dead and that therefore her ventilator should be disconnected. P.S. She wasn't. We know that because she was moved to a hospital in New Jersey and survived for quite a long time. And the doctor who made the initial brain death evaluation later concluded that he was wrong. But these cases, which are scattered around and really have not been adequately aggregated, these cases tell us that race is a very real factor in a lot of decisions about the kind of care that people get from different segments of our society. And so all you have to do is study the Jahi McMath case to understand that there is both the perception of racism in healthcare and, at least in some well-documented cases such as this, the clear reality of it. By the way, let me interject a quick answer to Desiree Bird's question. The number of people who respond to the HCAHPS, the Press Ganey survey, is tiny. It's usually 5 to 10%. It is broken out by hospital based on ethnicity to the extent that people provide that information, but that information is not as widely reported and studied as it ought to be. And of course, the unfortunate reality is that most of the survey responses are from people who were dissatisfied with their care, much smaller response rate from those who are satisfied with their care. Let's take a brief moment to pause for a CLE message. If you are going to be requesting CLE for the program, the first participation code is organizational. So scribble that down somewhere. You'll have to put it down on your attendance attestation. There'll be a second participation code near the end of the program, and you'll need both of them to get credit. So there are more tools that the law provides, including the Patient Self-Determination Act. This is a federal law that requires that every patient who is admitted to a hospital and seen in other settings be asked if they have an advance directive. And in addition to being asked if they have an advance directive, if they don't, they have to be offered the opportunity to prepare one. But this is another law that is largely a paper tiger. And as Didi will explain in some detail later, this is more of a problem for communities of color than it is for other communities. And the reason is that those individuals are more likely to be disconnected from the healthcare delivery system and not understand the importance, the value to themselves. In the case of Maria, for example, she had her partner present at the hospital, had not been given the opportunity to designate him as her healthcare agent, and that was a large part of what precipitated the crisis that she experienced. Now, the Patient Self-Determination Act is important. It is certainly a necessary tool, but is far from sufficient because it doesn't address the underlying problem of respect for the wishes of patient preferences as expressed by their surrogate. This is another article that is in the materials. I urge you to study this so that you understand what are the available tools and what are the deficiencies of the available tools to address implicit bias in the provision of healthcare. This has been the subject of a great deal of study by the government. This is a General Accountability Office study from 1995 about the Patient Self-Determination Act, about 5 years after it was implemented. Providers offer information on advanced directives, but effectiveness uncertain. That title kind of tells the story, right? So we need more tools, but we need to be using the tools that we already have more effectively. And I think that is part of the imperative that we want to drive home in the program tonight, that there is data out there. We can use that data to change behavior, but we have to take ownership of that. And then there's MACRA. MACRA is a sweeping law that influences everything about the way clinicians are reimbursed for their healthcare. It is a very interesting law because it incorporates lots of other legal requirements in a organized structure that actually influences the reimbursement that clinicians get for the care they provide based on how they are scored under this law. And one of the sections of MACRA, something that was folded into MACRA, is this notion of meaningful use of IT systems, which really is what we've been talking about for the last 55 minutes. But what the authors of the meaningful use provisions were thinking about was more, do you communicate with your patients by email, and do you provide access to charts by patient portal, such as the experience Maria had? It's a limited and, frankly, I'd like to say an unambitious notion of meaningful use. The kind of steps that Jorge was talking about a moment ago will take the notion of meaningful use to bigger and better places. Meaningful use has been a cornerstone of the federal government's funding of electronic medical records and the entire electronic infrastructure. So there's been a lot of effort put into making the use of a certified electronic health record a meaningful, positive influence on healthcare. And yet, as we've seen, there is so much more that meaningful use and electronic health records can be applied to. And that is part of the standard of care argument that I want all of you to take away from the program tonight. So now let's take a deep breath for starters and think about creating awareness and solutions. And when we talk about solutions, not just solutions to the healthcare provision problem and the implicit bias that is built into the way we currently deliver healthcare, but the broader conversation about promoting health at the community level. And with that, I would like to introduce Julia Rezari, who is the executive director of the Dalio Center for Health Justice, which is a quite remarkable and enormous undertaking that Julia leads to bring information to communities through education, to bring information back to the academic medical center through clinical and empirical research, and to use that information to then inform the way outreach is done to communities. Julia, welcome and thank you, and please inspire us.
I hope I can, but thank you for that warm welcome. My name is Julia Iyashira. I am a physician. I have been part of the Columbia New York Presbyterian family for almost 2 decades now. And I was recently appointed the executive director of the Dalio Center for Health Justice at New York Presbyterian. And for those of you familiar with our system, New York Presbyterian is the hospital, which is affiliated with both Columbia University and Weill Cornell. And I work collaboratively across our entire 10 hospital system. And I think it's really important that we start to think about the different forms that racism can take. I know that you had a phenomenal lecture by Nakia Alexander, and I was actually fortunate enough, she and I co-hosted an event last year sometime talking about microaggressions and interpersonal racism, But a lot of what I do in the Dalio Center is to think about implicit bias and is to look at how implicit bias can affect the care we provide. But it's also to take a much larger view and start to look at the structures and the systems in which we provide care. It's starting to look at how we think about and conceptualize health, and how health care, although a very important piece, and I will say as a physician, an important piece of this pie, is only about 20% of what it means for someone to obtain their optimal health. So we have to understand all of the other social drivers, and we also need to understand the influence of systemic racism on those social determinants of health. But first, I want to start just with a little bit about the language. My parents were both English professors, so I, more than most, understand the importance of language and the choice of words. And we chose the term health justice for our center for a good reason. We wanted to be provocative in our language. We wanted to think about justice and the pursuit of health as a right, not a privilege. And so I think it's really important that we own both the literal meaning and the figurative symbolism of that language. So what does health justice really mean? So I'd like to, I'll explain as much as I can visually. So picture three people of various heights trying to look over a fence. One person sees freely, a completely unobstructed view. The second, a little bit too short, can't see over comfortably, standing on tiptoes, barely peers over that fence. But the third person really sees only the fence, has no view at all. So how do we fix this? Well, when we think about equality, which we've heard a lot, and many of you already know these terms, equality is treating everyone equally. And in this scenario, it would mean that we give each of these people the same sized stool to stand on, regardless of their initial view, regardless of their height. Well, now our first friend, who already saw over the fence, has a better view. Our second, now firmly planted on her 2 feet, can see beyond the fence. But the box wasn't tall enough for our third, and they see only the grain of the wood. So to achieve equity, we actually now think about equalizing the outcomes. And we customize the tools, in this case, the stools or the boxes that we give people, in order to think about an unobstructed view over the fence. But coming back to language and why we chose the word justice, we wanted to ask, why is the fence there to begin with? What if we could think about the structural barriers and tear them down? Well, this is really what justice is. As I said, it's the ability for everyone to obtain their optimal health. It's when that becomes a right and not a privilege. Equity is, of course, and always will be central to the work that we do. It is central to our mission. But we wanted to focus on the structures and the systems, and you will hear me talk more about the systems at play here, both explicitly and, as you've already talked about before, implicitly as well. So as one of the largest academic healthcare systems, really twice over, we can and should be occasionally provocative in that language. We want to help advance the dialogue around the structural barriers and expose really the undercurrents and the continued influence of implicit bias and structural racism. So before we go any further, and for time's sake, I'm going to take the next sort of historical lesson quite brief, but I'm going to share a few slides to really hit home how we think about the work of the Dalio Center. And next slide, please. So we're going to start. This is a mortality map of New York City. Next slide, please. And in this case, I've highlighted 2 areas. The first is where I live on the Upper West Side. My life expectancy is presumed to be almost 80 years old. And then the second area is an area in central Brooklyn. This is Brownsville. Life expectancy here just above 70. So if I take the train from my house in the Upper West Side for about an hour on the 3, my life expectancy decreases by almost 20 years. from almost, as I said, 90 to a little over 70 in about an hour on the train. That's 1 year for every 3 minutes. And I'm actually always astounded when I think about that. I think sometimes the statistics and the numbers become so terrifying that we don't actually process them any longer. So I want people to pause here and reflect. That's 2 years for every mile that I move. And there are similar differences all across the United States. These maps are the same in many of our urban cities across the country. But we have to understand what is driving these differences. So we know it's more than just life expectancy. Next slide, please. There are differences in median household income. Next slide, please. In educational attainment. We can go to the next slide. Thank you. Next slide, childhood poverty. We look at severe rent burden, and these also are evidenced in housing insecurity, the presence of food swamps and food deserts. Next slide, please. And taken together, these are the influential factors that are the social determinants of health. As the CDC, this is one of my favorite definitions of them, as the CDC defines the social determinants, they are the conditions in which we are born, we grow, we live, we work, and we age. And if I do my job right, it's where people will thrive. So in addition to healthcare, I said healthcare is a big piece of this, but it's only about 20%. These are the factors that all drive health outcomes. There are numerous studies that link the social determinants of health with both short and long-term health outcomes. Next slide, please. We know that with increasing levels of educational attainment, your life expectancy increases. And here, plotted on the x-axis, we have years of education, and you can see that there is a large gap in those that have a high school degree and those that do not. So your odds of death increases when you don't have a high school diploma. This is a trend which we see as well in graduate education and through higher orders of education. Next slide, please. The same holds true with healthcare access. So this is a little bit of an old study, but it's looking at the difference of insured populations to those that are uninsured. And in this case, this is in the late 90s, showed that there was a 25% higher risk of death among the uninsured compared to those with private insurance. And in this case, we're using health insurance as a proxy for healthcare access. Next slide, please. This is a more recent study, and I'll summarize. I know it's quite small, but this is looking at the effect of poor housing conditions on both the incidence and then the mortality associated to COVID-19. So as on the x-axis, you see increasing quartiles, this is looking at worse and worse housing conditions. And this is showing both increased incidence of COVID-19 and then mortality associated to COVID-19. Next slide, please. We also know that with increasing levels of income, life expectancy increases as well. And this holds true across multiple populations, across all races and ethnicities. But next slide, please. One of the things that's very important for us to understand is how the social context influences these social determinants of health. So this is looking at log age-adjusted mortality and life expectancy between Black and white Americans. And what we can see here is that nearly at every year, and this is going back to 1900, there has been a significant gap between life expectancy of Black Americans versus white Americans. The only time that these two graphs touched was in 1918. And I know we are all frighteningly familiar with the effects of a pandemic, but 1918 was a similar pandemic. That was the Spanish flu. So we've learned and understood the effects of the social determinants of health for years. But I think for most people, the COVID-19 pandemic really brought them into stark focus. And although now I am directing a Center for Health Justice, I am first and foremost a physician. And so I was alongside my colleagues in the first and second waves of the COVID-19 pandemic, taking care of patients. And one thing that we saw quite early on, even when we weren't really sure what was happening, is we saw that there were disproportionately affecting and severely affecting the Black and brown community. So really anyone who knew and understood the impacts of the social determinants of health and the impact of systemic racism on the social determinants of health wasn't that surprised to see some of the more recent statistics. And although this graph here is just one of many, there have been other studies that look at education attainment. I already showed you that slide, but now if we look at the difference of mortality matched for educational attainment, but now looking at the racial gap, it's persistent that there is a difference between Black and white Americans, regardless of if there are Black Americans with higher education, they still have a large gap in life expectancy and mortality. And these are the studies that try to get at what is the influence of systemic racism on our society. And I think this is important for us to all understand, because when we try to think about how do we improve health care, we have to think about how do we improve health. Next slide, please. So the pandemic really magnified what was already occurring, added additional and deadly risk to already marginalized communities with significant pre-existing health inequities. And I really can't undersell the effects. So this is a graph of life expectancy. And for the first time in decades, life expectancy for everyone in the United States decreased. But you can see here that life expectancy for Black and brown men decreased by almost 3 years. That's 3 years of life estimated at birth that we have lost. But I really want to hit home how we think about some of these public and private policies that can influence the social determinants of health, and why, as a physician in a healthcare organization, I think about education, I think about financial security, housing insecurity, and I think about the effects of racism on all of those. So I'm going to take a short step back into history and show you a little bit about how we got here. So we have to think about unearthing, making the implicit explicit. I have studied science all my life, so I already told you this is going to be a brief foray into history. We could go back to the birth of the nation. We could go back to the origin story of the United States. We could talk about the effects of 200 years of slavery. We could talk about the perpetuation and legalization of segregation with Jim Crow, or even what we are seeing today with attempts at voter suppression across the country. This is a really complex history, and I do not have enough time to go through it today. But to start, I want to shine just a short spotlight on the 1930s. So if we can go to the next slide, please. This was, you can go forward to the next slide. One more. Perfect, thank you. So what you see here are, essentially we call these redlining maps. And on the right, this is Brooklyn, and on the left, you see Manhattan. So the goal here is my attempt to really underscore the influence of systemic racism on long-term health outcomes. So in the wake of the Great Depression, as part of the New Deal, the Homeowners Loan Corporation developed this neighborhood ranking system. Green areas posed quote unquote minimal risk to lenders, and real estate developers were incentivized to provide investment into these areas. Red areas were more likely to be the home to immigrants and of quote unquote undesirable populations. Areas that are red were frequently surveyors, and I've seen some of the original documentation, surveyors frequently took note of infiltration of Black and brown families and were considered hazardous. These were then redlined for investment. Federal backing was given to mortgages based on the grades, and banks simply refused to give loans to families of color, mainly in these red areas. And as we know today, homeownership is directly correlated with the creation and sustainability of wealth. We know now, I've shown you one quick slide to show that you can link wealth and financial security with both short and long-term health outcomes. And although this classification system ended in the 60s with the Fair Housing Act, echoes of this discriminatory practice are still quite evident today. Bank loan denials, predatory mortgage rates, deflated home appraisals, and the list goes on. But this is more than home loans. So if you look today, and these maps exist for almost every major city across the country, it's in Chicago, New Haven, Detroit, Atlanta, Los Angeles. Formerly redlined areas are more likely to contain food deserts and food swamps. They are less likely to have schools, less likely to have green spaces, and less likely to have healthcare facilities. These are all the social determinants of health. And unfortunately, they are more likely to be home to Black and Brown communities. So it's through this lens that we look at the racial and ethnic health disparities that we see today. They did not occur overnight, and they are the product of years of disinvestment and discrimination. They're the cumulative effect of systemic racism on the social determinants of health. Next slide, please. So take a look again at this life expectancy map of New York City. Next slide. And compare that to this map from 90 years ago. You can see some similarities. Areas that were formerly redlined are areas where we see very low life expectancies today. So this is the history we see in our communities. We have to be informed by this history. We have to understand the structural and the systemic effects of racism. We have to uncover implicit bias in the workplace, in the healthcare setting, but then we also have to think about how do we pull the levers of the social determinants of health to ameliorate what we're seeing in our communities today. This was a very brief overview and a sort of quick history of redlining in the United States, and it's really only partially complete. There are many books about this. There's The Color of Law, a forgotten history of how our government segregated America. And also there's a really great short video called on segregatedbydesign.com, which goes through this history. So I think as we start to talk about implicit bias in the healthcare system, we also have to talk about the responsibility of the healthcare system to own the other social determinants of health. If I'm really interested in making movement, in moving the needle in health outcomes, I have to also be interested in the home life that someone has, in their ability to attain education, in their financial security, and if they have food on the table. So as we start to think about initiatives and we think about interventions, that's the way we think about the sort of collaboration of the healthcare system and health. So I'm going to stop there. I get very passionate about this topic, as you can see. There is a lot of information that we have on our website, which is nyp.org/Dalio Center. And we have a whole host of the work we've engaged in over the last year, all again with this framework underlying all the work that we do.
Thank you, Julia Iyashra.
Yes.
I apologize for butchering your name. I'll do better next time. That was terrific. And as I was listening to your presentation, I was thinking we have in hospitals for generations been taking social histories. But they tend to be, has anyone in your family had cancer? Has anyone in your family been obese? It seems that if all of this became part of the required social history, such that this data was in the electronic medical record where we could access it, we would have a much better idea of what we have to do next for a given patient population being serviced by a particular hospital.
Absolutely. That is music to my ears, and it is work that we are engaged in across our entire system. So we have a long history with many of our faculty at our Columbia Uptown campus. I have to give a tremendous shout out to Dr. Dodie Meyer, who has championed social determinants of health screening for years. And we are now extending that to all of our hospitals so that we ask those questions of our patients. We ask, how often are they, unable to have food on the table? Mm-hmm. Is their home situation stable? Because when we prescribe medications or we discharge someone to a certain environment, we have to understand the interplay of their home life on what our sort of notepad prescription is for our patients. We have to take a little bit of a step outside of the traditional kind of swim lane of healthcare in order to really prioritize health. And I love the idea of leveraging our information technology system and our platforms. We've done a lot of work on our EHR. We are now, as a 10 hospital system, on one instance of the same EHR, so that we're able to share information easily. We're able to collect information about patients and use it in a responsible manner to help improve their care. So yes, stay tuned. A lot more work coming from our hospital system around social determinants of health.
All of which you should all know is designed to set an example, right? That's what academic medical centers exist for. And I think to the extent that these conversations that we're having tonight can perpetuate and spread, there'll be more of an incentive for more hospitals to look at their health promotion responsibility as part of their healthcare responsibility. And again, something that ought to be thought of not as an enhancement to healthcare, but as part of the standard of care for providing minimally competent care.
Absolutely.
So thank you, Julia. We have questions coming in. They are terrific. We're going to take a break to answer questions in just a few minutes. So please keep putting them in the chat box. And as soon as we hear from Didi, we will move on to questions and then have a discussion of more of the detailed ways in which we can use technology to enforce this standard of care obligation. And with that, we turn from the macro citywide perspective across all populations and all disease states to a sort of on the ground, in the weeds public education effort and effort to gather and analyze data in the case of the Washington Heights, Hamilton Heights, Inwood, Columbia Aging Project. Didi's work focuses on the aging population, in particular the population of Alzheimer's patients in a community of color, economically and socially defined as underserved, which is something that I think no one could dispute, and doing the really important work of getting people to understand what kinds of things they can do, such as advance directives, to promote their own health. So Didi, the floor is yours.
Thank you. Thank you, School of Professional Studies first, and David Hoffman for this invitation, and to fellow presenters for inspiring presentations. I think what I will start to say is that Julia, Dr. Ishiri, I can add to your presentation that YCAP has been doing exactly that for the past 20 years. I think we've been asking, what are those social determinants of health? But no one has really put their finger on it, I think, until institutes like Dalio are actually looking at it. And I consider myself a health equity researcher. And what does that mean? First and foremost, we ask questions that are actually trying to get at factors that we can approach in a way that we can help health advance or healthcare live up to its ethical obligations. In this presentation, I will briefly introduce the YCAP Community Research Study, review our institutional mandated consent procedures for assigning a surrogate, and summarize research on how advanced care planning positively impacts standard of care for families battling dementia. Okay. Next slide. Okay. So this is I'm so sorry, hold on. The slide before that one. Thank you. Okay, so since 2007, I've been managing the recruitment and follow-up of a multi-ethnic cohort, the Washington Heights, Inwood, Hamilton Heights, Columbia Aging Project. This graph shows 3 enrollment waves. The first wave started right around the hospital, and it was a diverse cohort. It had the same amount of cohorts that were non-Hispanic whites, African Americans, and Hispanics. As the community expanded, we had to, in order to keep the cohort diverse, we had to expand out. And if you look at this is the tip of North Manhattan. If you look at the blue circles spanning out to the Upper West Side, that's actually where we had to go to make sure that the cohort remained diverse. So as the population of whites expanded out, we had to move out, and it kind of shows in one way how redlining or segregation, or actually economic segregation, kind of pushed out and left behind the people who represent the Hispanic community. And as you can see, then the population of non-Hispanic whites were moved out to the Upper West Side. It is a unique cohort in that study participation is not limited to those that can come to us. We go to their homes and we introduce concepts of genetic research, AD progression, the benefits of scientific research, neurological and cognitive assessment. Next slide. The incidence rates for AD among our participants reflect disparities in who develops AD, most striking in later age groups. In those that are 85 years and older, approximately 11% of African Americans, 9% of Hispanics, and 4% of non-Hispanic whites meet the diagnosis of AD. Rates more than double among African Americans and Hispanics from earlier groups. In comparison, Alzheimer's Association report that 1 in 9 people aged 65 and older has Alzheimer's dementia, and older Black Americans are about twice as likely to have Alzheimer's, and older Hispanics are about 1.5 times as likely to have Alzheimer's, which is reflected in our community as well. Next slide. Here you see our interviewers conducting the medical interview and drawing blood on 2 of our participants. The YCAP core evaluation is considered a minimal risk study, but since this is an aging study involving individuals that may later have impaired decision-making capacity, our informed consent procedures must provide all the necessary additional safeguards to protect our participants from coercion or undue influence. Impaired decision-making capacity means the inability to receive and evaluate information effectively, or to communicate decisions to such an extent that the individual lacks capacity to manage his or her own research participation decisions. Next slide. This is how we document our informed consent. Completing the informed consent process is the first and foremost requirement for conducting a research study. All our staff is trained and certified according to regulations mandated by local institutional review board. For YCAP, it is the Columbia University IRB. Once the research participant is deemed to have capacity to consent, they are asked to assign a surrogate for ongoing study participation, should they lose capacity in the future. And this capacity is reassessed at every follow-up research visit. Next slide. As you can see, the Columbia University Institutional Review Board policy for surrogate consent considers whether there is a risk to subjects as reasonable in relation to anticipated benefits, importance of the knowledge to be gained from research, and allows them to designate a surrogate for future consent. Next slide. The healthcare proxy form, it is a document that we use that allows us to briefly review the subject's wishes with regard to research as expressed in their healthcare proxy form. They actually let us know if they continue to participate, what they want to do. They can opt out. They can say, well, we only want to answer questions. We don't want to do blood draws. So they can actually specify what is it within our study they allow us to do. Next slide. So now, how did our study fare when asking participants to choose a surrogate? We were a bit wary. We knew that there may be unsurmountable barriers that may impact the willingness of our participants to designate someone else to make research-based decisions for them among a population with present-day distrust of medical institutions and historical racist past of research studies. But as we saw in this chart, I'm sorry if I can't see that well, but the average age of those that chose to assign or not assign a surrogate was 80. So the years of education was about the same for both groups, 10 years of education. But the average number of evaluations for those that said yes was 4 versus 2. So over time, 97% of those that were asked to choose whether to assign a surrogate for future consent did assign a surrogate. But what was the difference? We found that the times that they saw us made a difference between us gaining our trust to allow us to make those decisions. To assign a surrogate. Authors Karen Burns found that surrogates' assessment of the risks and benefits of participation and their trust in healthcare professionals were critical factors in research decision making. Next slide. We looked at self-reported race and ethnicity in those who assign a surrogate. Out of the 1,912 who assigned a surrogate, 21% whites, 25% blacks, and 51% were Hispanic Latino. This mirrors the current demographics of the study cohort. Next slide. Now here we're looking at clinical dementia rating score. This is a rating system that assigns either 0 for those who are normal or are not impaired, a 5 for those who have mild cognitive impairment, and stages 10 to 40, where 10 is mild and 40 is severe dementia. Not everyone has been assigned a CCD, but those that did, 50% that had no impairment assigned a surrogate, and 42% who had mildly impaired or questionable dementia assigned a surrogate, and less than 5% were demented when they assigned a surrogate. As I had previously mentioned, being impaired did not necessarily mean that you do not have capacity to assign a surrogate. Next slide. Now, advanced care planning. How does that tie into what we're doing here in YCAP? Well, advanced care planning is the process by which patients, in conjunction with their physicians and loved ones, establish goals and preferences for future care. Advanced care planning for people living with dementia is important because it has been shown to decrease hospitalizations, increase concordance between care received and prior wishes, and increase completion of advanced care planning documents. The views of advanced care planning for people with dementia were clustered around 6 themes: timing and tailoring, willingness to engage, the roles and responsibilities of healthcare professionals, the relationships, the training, and the resources needed. Authors also concluded from this study that advanced care planning is acceptable for people with dementia and their caregivers and is associated with improved outcomes. They recommended that education on topics related to diminishing decision-making capacity is key to optimize advanced care planning for people with dementia and their caregivers. Next. Karine Pettigrew and authors found that respondents that were knowledgeable about dementia and hospice care indicated the person with dementia would want comfort care at the end of stage of life. And this was reported both for people who had legal advanced care planning and informal advanced care planning discussions. However, notable racial differences were present. Relative to white persons with dementia, African American persons with dementia were reported to have lower preference for comfort care and lower rates of completion of legal advanced care planning. Additionally, African American study partners had a lower level of knowledge about dementia and reported a greater influence of religious spiritual beliefs on desired types of medical treatments. But most importantly, all respondents indicated that more information about the stages of dementia and end of life would have been helpful and would have steered them in a way to actually wanting to complete an advanced care planning plan. Next slide. In this study, by Claire Banford and authors, 7 key factors required for the delivery of good end of life for people with dementia were identified: timely planning discussions, recognition of end of life and provision of supportive care, coordination of care, effective working relationships with primary care, managing hospitalizations, and valuing staff and ongoing learning. These factors span the entire illness trajectory from planning at a relatively early stage in the illness and to continuing care after death. In conclusion, this study confirmed the relevance of much of the content of existing end-of-life frameworks to dementia. Next slide. And how and why is planning for end-of-life care important? I will highlight a study that looked at palliative care approach across New York Presbyterian Hospital emergency departments, one of them being in Washington Heights and serving the YCAP community. From late March to mid-April 2020, when their emergency departments were at peak, the embedded teams evaluated more than 170 patients. They clarified patient goals of care in a timely manner, informed decisions on the use of life-sustaining therapies, and helped the ED teams deliver treatment that aligned with patient preferences. During this period, the ED-based palliative care team evaluated 110 ED patients. of which 97 had no documented advance directive or medical orders for life-sustaining treatment. After initial palliative care consultation, 71 of these patients changed their code status to do not resuscitate. The median time to change the code status was 5 days. During COVID-19, they quickly opened dedicated COVID-19 hospice units to expand capacity, permit family visitation, and allow primary teams to focus on acute care. The units facilitated frequent family video visits and an in-person family visit before death. Owing to visitor restriction, the hospice units were the only place in the hospital where family members were permitted to visit their loved ones for many months. And the families were incredibly grateful to spend their times with loved ones at the end of life, providing comfort and healing in otherwise devastating situation. Next slide. So YCAP community research study was able to engage over 98% of their participants about whether to allow a designated person to make decisions for them should they lose capacity to consent in the remaining of the study. It is well documented that ethnic minorities consistently report low health literacy regarding palliative care, hospice, and advanced care planning, which in turn leads to lower levels of engagement in advanced care planning and discussions with healthcare providers. While it is suggested that health literacy is an independent predictor of end-of-life preferences, others argue that literacy and racism present two separate but important pathways that must be carefully assessed to improve how the healthcare system ascertains and protects minority individuals' advanced care preferences. It is my hope that advanced care planning as a standard of care, at least for older adults, will create an opportunity for advancing racial justice through health policy reform. Next slide. And I would like to acknowledge these are the interviewers that actually go into the community and to the participants' homes. And they are the ones who are actually able to engage and assign the surrogates to our participants. I would like to acknowledge also the YCAP investigators who were instrumental in this program being implemented for the past 20 years. And I will close with a quote that I learned at the Health Equity Summit, which all researchers should strive for, that we should only ask the right research questions that will shift entire communities toward health and equitable, accessible care. Thank you.
That was just remarkable. I would very much like to find a way, and I think this is the work that we have before us, of expanding your interventions in Washington Heights, Hamilton Heights, and Inwood to the entire world. We can start with the rest of New York City and move on from there. It is astounding to me that you have achieved a 98% success rate in your interventions, when what I have seen in hospitals in my work as a healthcare lawyer and clinical ethicist for the last 6 years is 5 to 10% of patients have an advance directive.
Yes.
And when the question that is required to be asked by the Patient Self-Determination Act, do you have a healthcare proxy? The answer is routinely no. And in response to that no, the question is, do you want to designate someone? And I can count on my fingers and toes the number of times I have seen a patient designate a healthcare agent in response to that question, which tells us that people either don't know or don't trust the notion that designating a healthcare agent can provide some tangible benefit to them and to their families. So clearly, the work you're doing needs to be replicated as part of the standard of care for all hospitals, and to the point that Julia made, needs to become recorded as data on an individualized basis, so that it can be tied in with the treatment experience that a patient has and make sense out of what are the actual barriers to equitable distribution of healthcare resources. There's actually a question about that we'll get to in just a couple of moments. But thank you. That was absolutely terrific. And we're going to move to the second participation code. The second participation code, for those of you who are seeking CLE credit, is obligations. So organizational obligations. I tried to keep it simple. All right, and let's take a deep breath, everyone, and get to some questions. And if you haven't asked a question yet, I will ask one. Why not? I'm guessing all of you have questions. So please don't be shy. Put your question in the chat box and we will get to it. So a couple of really interesting questions, really directly related to Dee Dee's work that will be coming up in a moment. But the first question comes from Wendy DiCristina, who asks, what if someone has limited English proficiency, which we referenced in the earlier program, or has limited technology skills? Who can access the record on your behalf? Do you need a healthcare proxy just to access your EHR? And Wendy references what happened to Maria. So Maria was an extraordinary case because she was very engaged and very empowered, and yet was treated, regardless of whether race was a factor, really very badly from a patient care perspective. So let's go to Jorge first. Jorge, what is your sense of the role of both English proficiency and technological proficiency in our ability to provide ethically grounded care?
Well, part of the, I think, as a structural barrier per se, is the fact that we don't have any help in terms of like broadband access or technological access for certain communities. And there is like no coordinated effort or plan to address that at this point yet. And again, part of the issues I used to see, for example, was like, oh, we cannot give you the record while you're in the hospital. And part of the workaround was being able to access your medical record, and you could sometimes see it in real time how things were going. But again, if you don't have that access to a smartphone, which we take for granted, but not everybody has one, or you just don't have access to broadband, or you just don't have the technological skills to do it, you're again kind of kept in the dark of the type of care you are receiving right there, and you just don't know unless you have a meaningful engagement with the team, which sadly doesn't happen often as we would like. It is again affecting the type of care you're receiving because you're just not engaging with it, and you're just this passive patient there taking whatever they're giving to you with no real feedback or any issues or questions that you can ask. So
yeah, I'm struck by the notion that possession of a cell phone, a smartphone, is its own barrier and its own social determinant of health, as demonstrated by Maria. And I wonder, Julia, what can we do with that insight?
Well, there's actually a fair number of healthcare organizations who have started work in this area, whether or not it's in providing the actual access for patients. So whether or not they're providing devices, I know of a number of institutions doing pilots that provide devices and service to patients, particularly because in the wake of COVID-19 and in, as we were ensuring safety for our ambulatory spaces, much of our practice model switched to telehealth in the midst of the pandemic. And that's something that, we don't really see changing. We see that now as a completely reasonable alternative to going into your physician's practice or your office. So a number of things had to be done. In the beginning of our launch of telehealth programs, we actually had virtual navigators. So people that would call patients and make sure they could figure out that had the technological capability to sign on to practice, to the virtual space for their visit. We also have, for some of our social determinants of health screens, those are done on iPads in some of the office spaces. So again, part of Dr. Meyer's work has been using, again, navigation in the actual clinic space, people that come by and help explain that platform to one of the patients and help them navigate the surveys. Because I think there's also there's the device, which is a barrier. There's the access, which is a barrier. Then there's also virtual and technical literacy, which is a barrier. And then on top of that, we have both traditional issues of health literacy and then just fluency. So, a lot of the times when we're looking at our medical records, those are in English. And so I think there's multiple layers of this problem that we have to try to unpack, but there's a lot of people trying to take this on. There's both some foundations and organizations who are providing service and devices. Then there are healthcare organizations like our own, which are providing some of the virtual navigation so that patients can more easily get onto these devices. But I agree with Jorge. This has to be something that is, and it has been on the agenda for both local and national policy, but I think this is something that we have to take on at like a federal and a state level to really get into some of the communities that most need device or most need access. The digital divide is quite real and is becoming an even more important problem that we need to face. So I champion Jorge, and I think you brought up the right problem. I think it's going to take it's not just the healthcare systems, it's going to take a large movement to really get access to people that need it.
I just wrote down digital divide as one of the touch points for our discussion. Interesting, because the digital divide historically has been a notion of access to a computer for educational and information purposes and access to internet, so that you are literally connected to the system, the water pipes that provide information. But this notion of a healthcare digital divide, as we have embraced for good reason telehealth, telepsychiatry, teleradiology, this is making the notion of a digital divide not just an education and awareness parameter, it's making it a matter of life and death. It also occurred to me in the context of meaningful use and the way MACRA incorporates meaningful use into reimbursement, that we've done something well-intentioned but rather insidious, right? We've taken a right to access to your health information and turned it into a duty or an obligation. It was intended that patient portals would enhance patients' access to health information so that they could be engaged and ask good questions. Now it's become not an enhancement, but a barrier. It's become, in many respects, the exclusive means of getting access to information in real time so that you can ask meaningful questions. And this is sadly another manifestation of the law of unintended consequences. And what's happened with telehealth in COVID, I think, is a shining example of that. I'd like to turn to Didi on this question, because Didi, you see people, your team is in people's homes. Where does cell phones, smartphones, access to the internet, where does that fit into the experience of your researchers?
Yes, so that's a very good question. So we did pivot right away. Within a week, we had gone remote, but we did find that within our cohort, the years of education really correlated with who knew how to do Zoom visits. So most of our participants with lower education, which also happened to be most of the monolingual Hispanic participants, were only able to do a third of our visit. And then we actually started doing workshops in the communities, and we actually called it Digital Divide, which was, so we did start doing that, and we found that it was harder than anticipated. So we pivoted again and said, you know what, we've learned our lesson. We're just going to do phone assessments. And there's actually, I think, research going to be published soon about the difference of approach, let's say, for people who were more educated, they were able to do Zoom visits, and they actually got to have a better assessment, although it was research. And we actually were able to, they were not able to go to their healthcare providers, but we were actually able to find, because we do a medical assessment, we're actually able to, to find a way for them to see their healthcare providers. And we actually averted some medical emergencies from during our calls. So yes, it was an experience.
Interesting. My colleague, Arthur Kuflek, who teaches our philosophy and bioethics course, is fond of observing that some services, as a matter of ethical obligation, ought to be provided to everyone, regardless of their means, such as police and fire service. Others, we should be on our own, such as fancy cars. I wonder where a cell phone fits. Clearly, not so long ago, a cell phone was a luxury. It strikes me that if you are deeply immersed in the healthcare delivery system, if you have a chronic or acute disease, maybe we have to consider a smartphone as important to a person's health outcome as the paper prescription we used to give patients when they leave the hospital. Because as evidenced by Maria's experience in our case study, if you don't have that access, you are quite literally flying blind. So let's go to our next question, which comes from Chanel Martineau, I hope. And I apologize if I didn't get that right. What are the structural barriers you're referring to? So, Chanel, I think we've been talking about a few of those just now, but there are others. Julia, you want to talk about structural barriers some?
Yeah, I think, when we think about the structural barriers, we are thinking about the influence of systemic racism on the social determinants of health. So we're looking at, so you take them pillar by pillar and can identify major barriers. So when we're looking at the education system, it's who has access to not just early education and early development. So looking at access for pre-K and kids, looking at the location of all of our schools within a city. So we know that they are not equally distributed. We know that kids don't have the same access to certain charter schools or certain public schools. So you can look at that across the board in education and access to education. Then you look at finance and access to the financial market, access to jobs. Actually, all of these are the structural barriers that we talk about. And they all are part of these social determinants of health. So there are numerous in each of these, but if you think about it, so housing, it's access to affordable housing. It's access to affordable housing that is not in disrepair. It's access to affordable housing not in disrepair that doesn't have lead and doesn't have asbestos and has an air conditioner. So those are some of the structural barriers that we start to think about when we're looking at overall health outcomes. There's far too many to list here, but we bucket them into the social determinants of health.
And I would only add access to a sustained relationship with a primary care provider.
Yeah.
It is an unfortunate reality in medically underserved areas that turnover is great. And if you don't have that sustained relationship with a clinician, you're not going to have either the confidence or the insight to ask the important questions. In the Bushwick section of Brooklyn, where I worked at a hospital for decades, just the notion that you lived could find a clean enough building to live in that your children wouldn't suffer from asthma. If you were confined to a particular neighborhood by redlining and other influences, you might not ever be able to find an apartment that didn't have contaminants productive of asthma. And asthma is, we should all remind ourselves, a completely preventable disease condition. So we clearly have lots of work to do in that area.
I would like to add to something that you said.
Please.
Was that it took an average of 4 visits for us to get for us to get a family to assign a surrogate. So again, it just shows that you need continuous contact with a family so they can, even when we mirrored who they were. As you can see, our staff, most of them were Hispanic and of color. And even then, it took about an average of 4 visits, because we see them every 18 to 24 months, for them to come to assign a surrogate. So I just want to say that it's not, they saw us and they say yes. So it does take continued work.
Right. You have to be in it for the long haul.
I want to echo that as well, because as she said, it is a process, and sometimes we would get clinical teams a little impatient sometimes and be like, oh, did they say anything? Did they assign somebody? And it takes a little bit of education as well for them to understand that this process takes time, particularly with certain populations or not. And that is something that sometimes time is a luxury in medical care, but sometimes we have to just make a little bit of time for that as well.
Yeah, I think maybe more than a little bit of time, because if these indicators and these processes don't become part of routine care, if they're looked at as an enhancement, as a luxury, we're not going to solve this problem. And as we discussed earlier, to the extent that all of these factors that we've been talking about can be incorporated in the social history, and incorporating in the history and physical process, the question owned by the physician, including the resident who is doing the history and physical, do you have a healthcare proxy? And if you don't, who do you want us to talk to if you're not able to speak for yourself? And do you want that person to be your healthcare proxy? I inserted those questions into the history and physical form at my hospital in Bushwick 25 years ago, and it moved the needle just a little bit. But we have to do much more of that, to be sure. All right, Kathy Lee asks, I wanted to ask, how do we address and provide equity in healthcare when many people of color have been negatively affected by the U.S. healthcare system, such as the Tuskegee syphilis study? We cannot say enough about the Tuskegee syphilis study as a almost uncurable damage to the trust relationship between communities of color and the healthcare delivery system. So, anyone have a magic bullet?
So I'll jump in here. First, I think there is no magic bullet here. This is when we think about, so for many, Tuskegee is an exemplar of how we can build distrust within communities and mistrust within communities. It's the abuse of Black bodies in the United States. But Tuskegee is the tip of a very large iceberg. So when we start to look at the history in the United States and the history of medicine in the United States, Tuskegee is one of many, and probably not even the worst in many cases, for how we have thought about really the building of a long-term history of abuse in this country. And so I think, one, it's a recognition of that history. It's us saying this is what has happened in the United States. This is how we have created our modern medicine. It's a recognition that we have to own that. And then it's putting in the time. It's saying, we can't forget what has happened. We have to build new trust with people in the future. And there's actually a lot of studies that said that, when we were looking at vaccine education and we were trying to get people to understand a little bit about the vaccines and build this trust with people, Tuskegee was cited quite frequently. It just meant that we needed to put in more time and effort to explain and build the trust, and we were able to do it. But you couldn't say there's no magic bullet, there's no way to get around it. You got to own it as a history, as a horrible and as a really terrifying history in the United States of medical misabuse. But the way forward is not to ignore it. The way forward is to own it, to acknowledge it, and to say that we have to build trust and we have to be responsible in the future. So for those of you that are actually interested in knowing more about this, Harriet Washington's book on medical apartheid, I recommend. There are countless incidents that date back centuries. So I would recommend taking a read and understanding, where some of this history comes from and why people have completely reasonable distrust of the medical community. It's on our part to fix that. So, and then when I say our, it's the medical community. We have to fix that. We have to build the trust. We have to become responsible parties.
Harriet Washington, a member of the faculty of the Bioethics Master's Program. So thank you for mentioning her.
Of course.
That's terrific. So we have a follow-up question that sort of ties in with the discussion we were just having, again from Chanel. Are the areas with lower life expectancy also areas with higher violent crime? And I can speak from my experience at inner city hospitals for 30 plus years. Yeah, sure, because those areas are also areas with more poverty, with more social disconnection, and it's very much a vicious cycle, and it sort of extends from the distrust of institutions that is sort of exemplified by Tuskegee, but to Julia's point, Tuskegee is far from the most important example. Any other thoughts about poverty and violent crime as a social determinant of health and part of the responsibility that healthcare organizations have to gather that data?
So I will say, if you look at the overlay maps, they actually don't overlay exactly. So when you look at these areas that have, higher mortality or lower life expectancy, that doesn't actually overlay exactly with areas of higher violent crime. And so I think that we have to try to unpack what the question is, what's sort of I think the goal of the question, which is that when we look at all of these measures, my goal is that we need to help develop communities that have all of the opportunities for success. And so that means that they have schools, they have green spaces, they have access to, a home that is not in disrepair. They have all of the opportunities that people need. And there's actually been studies to show that when you match people with a community that has all of the necessary opportunity, a lot of the differences between, some of the racial and ethnic inequities that we see, health inequities that we see, disappear. So it's about building a network of community of opportunity for people. And I think that's really when we're starting to talk about some of these measures and metrics, because no, they don't exactly overlay. I do think that I agree with you in areas of poverty and areas we do see differences in crime rates, but I don't think I would not say that there's a direct correlation there. I think it's actually just looking at what's the opportunity available to people that live in those areas and how are we setting them up because of disinvestment in those areas. How are we setting people up for, we are not setting people up for success. So I think that's where we need to sort of refocus the conversation.
And I think it is the disinvestment and the lack of support that fuels the distrust of institutions that gives us many of the problems that have been so intractable. Jorge, did you want to add anything, or Didi?
I will have to say, follow up with what Julia said, which also as a researcher going into communities, a lot of the times what I get back as well is how we researchers I'll include myself at the beginning, we don't give back, or we take and we don't give back as much as they give us. So one of the things, that came out of that is that we go to the community at least once a month and we disseminate our research results and we let them know what we found in our research. And that has led to more people. We go to the community for the education, and that has led actually for our recruitment to go higher because, we've touched on something that a lot of people in the community used to complain about, what research does and what does it do. And then the more they learn, the more they're open to it. And the same thing happened with the vaccine education we were doing as we started to go into the community, explain what, how it came about. And the more time it took, the less hesitant they were to get the vaccine. So I feel sometimes like the present moment, the things that are happening now, researchers that go into the communities and just ask questions and don't go back and disseminate their results. That's one of the things that they, let us know and made us successful, because we listen to them, and we go now once a month to local senior centers and explain what our research is doing or what it's not doing. And that has helped us, decrease the hesitancy to participate in research studies.
And clearly, Didi, your work with YCAP has been the example of what we ought to be doing, which is pairing extracting information with providing information, pairing deriving academic and intellectual benefit with providing service. And that has clearly gotten lost. So Phyllis asks a really tough question that we need to take ownership of. Phyllis asks, how do the assessment of the social determinants of health by individual physicians translate into the lessening of disparities due to these structural determinants in real practice? Anyone?
Maybe I can start by saying that we tend to think of this issue very individualistic, as something that the physician or the practitioner in general has the ability to essentially solve in the patient and practitioner relationship, when really there is way more. Again, reframing the question to the structural barriers that are there. And we can talk about training to physicians, we can talk about reframing questions or things that clinicians can do, but that is only just a small dent on a bigger issue again. And maybe it's not that we're asking healthcare systems to do everything, right? But structural issues require structural solutions. And we're asking to enable partnerships, right? To use their market and political power to be drivers of change, and it's not by reinventing the wheel like we've been saying here for the past hour. We have the tools already. We just need to be smart about it and positively impact our communities.
Yeah. Oh, go ahead, Julia.
Yeah, I completely agree. I think there's both the individual. So a one-on-one physician asks a question, screens for social determinants of health, and then is able to provide service to that patient. So, if they need to be referred to a community-based organization or a food pantry or, whatever helps to meet their immediate need, then we're able to supply that. But then I think when we start to look at population health, that's where we also start to look at when we're looking at data sources and data sets that are of zip code level, census tract level, looking at cities and states, we start to understand what are some of the large scale barriers and what's the role of advocacy. And so I think, one of the reasons I brought up voting earlier is because I think of voting as a right. Like this is our ability to change policy. This is our ability to change the structures that are in place to really improve the health outcomes. So I think there's both the individual level and then there is the population health level. So that's both in terms of structure and policy and advocacy. And I also just wanted to clarify earlier, I'm really not in the habit of adjudicating travesty. So I'm not to say that Tuskegee was not the worst. It's simply one of many. And it is equally as horrific as many other things in history. So I just want to be clear that I'm not trying to provide one is better than the other. They're all horrific.
Yeah.
But I do think that when we start to think about levels of influence, there's the individual sphere of the patient and the doctor relationship. And then we start to broaden when we start to think about systemic effects or structural effects. And that's where we get into public and private policies. That's where it's, I was showing the redlining maps earlier, because they have long lasting effect.
Absolutely. Look, what's special about Tuskegee is that everyone knows the name. That is really the only thing that's special about Tuskegee, because other than that, it is just one of many, many research travesties, and the research travesties are only a small part of the larger problem. To answer Phyllis's question, Phyllis, I want to answer your question directly. What individual physicians can and should do that will translate into lessening of disparities is to ask the questions, to collect the social and personal history, to record it in the electronic medical record so that people like the four of us and lots of other people have access to individual level data that can be aggregated to try to tell the bigger story. And so I think that's what physicians have to own, and all clinicians, not just physicians. You asked about individual physicians. It's clinicians up and down the ranks. If they don't feel as if it's part of their obligation as healthcare providers to document the health status and the health influences of their patients' lives, then we're never going to have the tools we need to actually change this. So that's my answer. All right, let's move on to Heather Miller. Heather asks, and I think this is regarding our case study with Maria, was the surrogate in lieu of a legally authorized rep? And then she goes on, so the surrogate is a member of the organization. So Heather, you ask a whole variety of questions that touch on the intersection of law and bioethics. Surrogates have both a sort of a lay meaning, an ethical meaning, and a legal meaning. In the broadest sense, a surrogate is someone who acts on behalf of somebody else. But in New York, a surrogate is someone from a patient's orbit who steps into the role of decision maker by virtue of their status and relationship with the patient, different from a designated healthcare proxy or healthcare agent pursuant to a proxy form. That's what Didi was talking about a moment ago. And all of that is different from someone who is appointed to act on behalf of a patient by a court or through some internal structure of a hospital. Those are often referred to as guardians. And that is the least desirable way of approaching these questions. And if you want to do some more reading about this, I recommend to you The Case of Mary Northern, something that we discuss at great length in my bioethics classes. All right, let's move on to, how are we doing on time? Let's move on to Gillian. In what ways may the general move to telehealth impact potentially psychosomatically informed health outcomes compared to in-person visits with physicians? And Gillian, I think you're asking the narrow specific question that more broadly is defined as what is the downside that balances the upside of telemedicine? Anyone?
Sure, I'll take a start. So I think that with many things, we have to identify what are the upsides and what are the downsides and try to mitigate those downsides as much as we can. And, you know, as someone who has practiced medicine and been in a hospital for decades, I really have, I feel I have like a visceral reaction to not being able to like lay my hands on someone and to listen to their heart. And so I don't think that telemedicine is ever going to completely supplant the physical. You have to be seen by someone in person. So I think we're looking at telemedicine as an addition, so that, you know, if someone needs to be seen by their physician or other clinician every few months, it can be an in-person visit and then have other sort of telemedicine visits in the interim or for additional service. So I don't think it's ever going to completely supplant that, because there is a magic to that interpersonal relationship that you build with a clinician that you really can't get in other ways. But this is where data is really important. And this is where we have to study our own data to understand, are we able to meet the needs of our patients through the telemedicine platform? who is seen by a telemedicine, and this is what I'm actually on a sort of national telemedicine association committee looking at health disparities. And, we have to look at things like who's seen on, by a telemedicine visit and then still comes into the hospital later. We have to understand, are we able to meet the needs? And if we're not, why? Or what was it about that encounter that didn't actually meet the needs of the patient? So I think there's pluses and minuses to all technologies. I think there's things we have to think about. And I think there's sort of some of those the downside risks we need to mitigate, but that's where data becomes really important. And I will say, I hope that we never fully replace the one-on-one physical connection that we have with our patients. That's really why many of us went into this, is to be able to lay hands on people and to sort of listen to their heart and listen to their lungs. I don't think any technology is ever going to replace that.
I wish I could be as hopeful as you, Julia, but from my perspective as a hospital attorney and clinical ethicist, I see forces moving in a dangerous direction. This is another example from an ethical perspective, another example of a right turning into an obligation, right? Telehealth was an enormous boon during COVID. But it has gotten a lot of people's attention as a less expensive way of providing care. And I see this as very much analogous to an issue that we look at in the ethics of clinical psychology. Group therapy is sometimes the best form of therapy for certain conditions, but often it is the modality that is utilized because though the patient would benefit more from one-on-one individualized therapy, it's simply not available. It's not cost effective and therefore not priced in a manner that many people can afford it. And therefore, group therapy is the second best. I am afraid that telemedicine will take on a life of its own and it will become the more affordable second best, which very much ties in, by the way, to Angela's question. I was curious about the role of insurance companies in ameliorating these implicit biases. I think insurance companies have an enormous amount of data, an enormous amount of influence. It is the essence, in fact, of managed care. They also have the potential to be a negative influence on our project of ameliorating implicit bias. Any thoughts on insurance companies, or would we rather not think about them? So let's move on to a question from Ann Zimmerman. What about those who do not want their clinical care to expose them to social services that they do not want? Are people at risk of being subjected to any social service surveillance due to bias? And I think, Anne, that's a real problem. The notion, again, of a right turning into an obligation is ever present. And we need to be sensitive to the fact that sometimes, though a clinician or an institution may feel that a certain kind of discharge plan is in the patient's best interest and a certain type of involvement in the patient's life beyond the care they came for is warranted, again, think of Maria, that right to access ought not to be an obligation to accept a type of care that the patient doesn't want. And when the threat of declaring the patient decisionally incapacitated is invoked, then we're talking about coercion, right? All right, let's wrap up with a quick look at something hopeful. So we can go back to our slides and ask the question, what do we need to consider and where do we go from here? And I will tell you, as we have discussed for the last 2 hours now, we have the tools. We just have to learn to apply them to these new challenges. And that will involve clinicians acknowledging and internalizing the obligation to ask these questions, record the data in the electronic medical record, give meaning to the notion of meaningful use of this enormous investment that society has made in electronics, but at the same time not lose sight of the fact that what the patient needs is more important than what the government needs. And so the first tool that we can apply to our electronic medical record is data mining. And that is this notion that we can so easily draw massive amounts of specially filtered information from the electronic medical record, de-identified in ways that we never could before. And we are not adequately harnessing that ability as a threshold use of the EMR. And the second one is producing exception reports. And that, again, is harnessing the power of computers to filter out all of the successes so that we can focus our attention on the problems, on the challenges, on the opportunities for improvement. And what we're going to do here is take these tools and move them into a whole new realm of health advocacy. And that's what we need to mean by meaningful use. This is not your grandparents' meaningful use. This is a whole new definition of what meaningful use can and ought to be. And with that, I want to say thank you to my friends and colleagues, Didi, Jorge, and Julia. I think we have started the ball rolling. I think we've barely done that. There will be a third session of this project, which is to focus on what that data mining, what that exception reporting, what that use of technology should look like, so that all of you who took the time to be with us for this 2 hours can advance these arguments in your institutions and with your families and friends, so that we can start to get this problem quantified and qualified. So with that, I'm going to say good night and thank you. I urge all of you, if you didn't get to see the first chapter of this project, to go to Columbia Bioethics on the Columbia University website and look that up. We have a slew of other programs available on a broad range of topics that touch on the intersection of law, medicine, and bioethics. So thank you and good night.